The role of breathing in manual therapy. Breathing techniques in manipulative therapy. Practitioners of manual therapy, including chiropractors, osteopaths, and physiotherapists, place considerable focus on the patient's breathing patterns during treatment. Techniques are often timed to coincide with exhalation, and this approach is supported by several physiological reasons. Exhalation is less demanding. In comparison to inhaling or holding one's breath, exhalation is typically much less strenuous. It occurs passively due to the natural elastic recoil of the lungs, without active muscular effort. Additionally, gravity assists in pulling the ribcage downward during this phase. Exhalation promotes calm, slow, controlled breathing, especially during prolonged exhalation, can trigger a relaxation response in the body. This is due to the activation of the parasympathetic nervous system, which helps regulate and lower heart rate, blood pressure, muscle tone, and stress hormone levels. Exhaling enhances posture and spinal control. During exhalation, the diaphragm and external intercostal muscles relax, reducing thoracic cavity volume. Research suggests the diaphragm plays a key role in both respiratory mechanics and stabilizing posture. Hodges and Gandevia, 2000. Working together with other core muscles, the diaphragm contributes to intra-abdominal pressure, which can in turn support spinal stiffness. Practitioners may also synchronize their own breathing with the patient's exhalation to optimize technique effectiveness, commonly encouraging the patient to breathe out as they apply a force. Why breath holding is avoided in manipulation. Holding one's breath during spinal or manual adjustments is contraindicated due to potential negative effects on physiological function. Oxygen delivery is essential for healthy tissue function, and when breathing is temporarily halted, oxygen levels fall while carbon dioxide accumulates. Lin et al., 1974. This leads to unstable blood pressure regulation, often a rapid rise followed by a sharp drop, and symptoms like fatigue, dizziness, reduced concentration, or even syncope. Scow et al., 2015. Furthermore, muscle activity related to respiration is impacted during breath holding, and applying manual force under these conditions may place excess strain on the thoraco-abdominal area. This can compromise postural support and core stability during treatment. Overview. Cervical spine manipulation, CSM, has long been applied to address numerous issues affecting the head and neck, including stiffness, pain in the upper spine, cervical disc degeneration, and headache or migraine symptoms. While many clinicians consider CSM to be generally safe and effective due to its relatively low rate of adverse outcomes, Killinger, 2004, recent literature has raised awareness about potentially severe complications, some even life-threatening, associated with its use. Di Fabio, 1999, Ernst, 2007, Leon Sanchez et al., 2007, Gouveia et al., 2009, Quentadura et al., 2012. Contrasting viewpoints suggest that such adverse outcomes may not stem from the procedure itself, but rather from insufficient practitioner training, poor technique execution, or inadequate clinical assessment. Refshog et al., 2002, Hanaline and Triano, 2005. This highlights the critical need for appropriate anatomical knowledge and clinical competence before initiating cervical manipulation. The following section provides a breakdown of cervical joint structure, motion ranges, common injuries, and critical warning signs relevant to safe practice. Joint anatomy of the cervical region. The cervical spine includes the first 7 vertebral segments, C1 to C7, beginning below the base of the skull, and extending to the upper thoracic spine. Functionally, it is categorized into 2 segments: the upper cervical spine, OC2, and the lower cervical spine, C3, C7. The upper portion is more specialized and comprises the occipital bone, O, atlas, C1, and axis, C2. In contrast, the lower segment exhibits typical vertebral anatomy: vertebral bodies, spinous and transverse processes, laminae, pedicles, and zygapophyseal joints. Dodwad et al., 2014. Motion characteristics. Among all spinal regions, the cervical spine offers the greatest mobility. However, its movements are intricately coordinated. Movement at one vertebral level involves simultaneous but asymmetrical motion at adjacent levels. Van Mameren et al., 1989. Movements occur in 3 planes: sagittal, flexion-extension, coronal, lateral flexion, and transverse rotation, allowing a wide range of dynamic motion necessary for head orientation and upper body posture. Common cervical injuries. Severe trauma to the cervical spine is often linked to falls or vehicle-related accidents, which may lead to vertebral fractures and result in neck pain, spinal instability, or neurological compromise depending on injury severity. Toretti and Sengupta, 2007. Frequently impacted regions include the craniocervical junction,